Hello and welcome to another ICS Impulse video. I'm Wendy Crumley-Welsh, the product manager for ICS Impulse, and today we're going to be talking about gaze. The gaze test, which includes gaze and spontaneous, is in the ocular motor module. Gaze tests provide the ability to assess for gaze and spontaneous nystagmus. The purpose of these two test types is to identify nystagmus that is evoked without stimulus by having the patient stare at certain positions. The patient is typically in a sitting position or in a caloric position, the caloric position being the head is inclined 30 degrees. Gaze assesses the patient's eye movement when the eyes are fixated in different directions, left, right, up, down, and center. The person assessing the patient will provide the stimulus at which the patient is to stare. This stimulus can be tester's finger, an implement, for example, the tip of a pen or a bobby pin, or a laser light presented on the wall from a presentation remote. According to the ANSI standard, the eyes should be recorded for a minimum of 10 seconds with the eyes positioned at 30 degrees from center, right and left, as well as 25 degrees from center for up and down. In order to assess for alternating or direction-changing nystagmus, the eyes should be recorded for more than 2 minutes. Please be aware that having the patient look further than the degrees stated above can result in endpoint nystagmus, which is not diagnostically relevant. Gaze tests may be performed with vision or with vision denied. Regarding the spontaneous test, this test type assesses the patient's eye movement when the eyes are in the primary position, looking straight ahead without any visual stimulus. According to the ANSI standard, the eyes should be recorded for a minimum of 20 seconds. The patient or patient's head may be in various positions such as sitting, supine, chin to chest, or head extended backward. The spontaneous test may be performed with vision or with vision denied. Regarding pupil detection, calibration, and vision denied solution, these are covered in other videos. Regarding goggle placement, the goggles obviously need to be affixed to the head, but they do not have to be put on as tightly as they do for head impulse because the head is not moving. For eye video recording, the eye video is always in grayscale, no matter if you use pupil location or grayscale image. You just need to make sure that the record button under video recording is checked. And then the head position feedback or synchronized room video can be used. Now, why would you want to do this if the head's not moving? Well, you want to make sure the head's not moving. So obviously, if you're sitting in front of the person, having them look at your finger, you can also keep an eye on their head. But it's also a good thing to do if you record the synchronized room video or the head position feedback. You can also play back that information. So you can go back and look at your data and make sure that the head wasn't moving. The last two things, external monitor and presentation remote. If you click this button down here that says external monitor, you can then display the eye real big on an external monitor. It'll also include the slow phase velocity, the head position, the gaze position feedback, Now regarding external monitor and presentation remote. If you want to use an external monitor, you click this button right down here. On the external monitor will be the eye video, the slow phase velocity real time, the lapse time, and also the gaze position. The presentation remote can be used to start and stop the test or even put in an event marker during the test. So let's talk about test setup. You have three options: gaze, spontaneous, and other. So you choose which one you want. Other can be used for anything, and that name can be renamed. So if you want to call it something else besides other, you can put the name into your system. Then you have vision denied. If you're using the vision denied solution, you check that box. And if you want to record torsional eye movement, you need to check that box. Now that is something that is a purchased feature. So if you have not purchased it, that will be grayed out. Then you have your drop down of all your maneuvers, and then the last two things are the torsional reference frame and the ROI position, which are covered in other videos. So in the drop down, you have several options: center, left, rebound, right, up, and down. So when you get ready to do your data collection, you want to first instruct the patient. Make sure they keep their head still, make sure they're looking at the direction you want them to look at, and then we're going to talk about the gaze position, the real-time SPV. The gaze position tells you how many degrees that person is looking. And then the real-time SPV is the slow phase velocity. What's the robustness of that nystagmus? So here, the green number is 19. And green means that that is a very consistent response. That response isn't changing very much. If the person's looking around and you're getting random eye movement and it's picking something up, then it would not be green. It would be yellow, but or orange. The SPV, if it's green, that means the nystagmus is staying consistent. And then the gaze position number. So that's the degrees to which the person is looking left, right, up, or down. So let's actually open up the software and show you how gaze position works. Okay, when you get ready to do your gaze, you want to turn the laser on, and this is your center laser. And so it's sending its laser straight in front of the person's head. And you want to make sure the person's head is straight and they're staring at that red laser, and then you click center. And what this does is gives you a 0 reference for your gaze position over here. Now, then you ask the person to look left. So if they look left, that becomes a negative number. If they look right, that becomes a positive number. Now what you can do is you can get the person into position as soon or before you actually start collecting data. For rebound left and rebound right, you would want them to be looking off to the left, and then when you hit start, you want them to move towards center, and that's going to give you your rebound nystagmus. So I'm going to show you now some data collected on a patient who has normal results. When the patient is looking downward, you will need to remind them to have their eyes wide open, because sometimes the eyelashes kind of cover the pupil a little bit, but if they open their eyes nice and wide, then you won't have that issue. So first we're going to do left. So we're going to ask the patient to look left. And again, since this patient is within normal limits, we don't see much in the trace. It's pretty much a flat line. Once you're done collecting, you click stop. Now you choose the next position, so we choose right. Ask the patient to look right. Again, no nystagmus, fairly flat trace. Then when we want the test to stop, we click stop. Again, you could set the test to only run 10 to 20 seconds and then have it automatically stop for you. Now we're going to ask the patient to look up. And again, no nystagmus. And we're going to stop the test. Then we're going to set it to down, and we're going to ask the patient to look down. Again, no nystagmus. So we're going to stop the test. And last one, let's do center. So we're going to ask the patient to look straight ahead. And again, no nystagmus. And then we're going to click stop. Now we're going to talk about data analysis, and then following that we're going to talk about playback. So let's go back to the software. After you've collected data, you have two tabs to look at analysis. You have the analysis tab and also the gaze graph tab here. So the first thing we're going to do is talk about the analysis. So the red trace is your horizontal right, the purple is your vertical right, and then If you had torsional, you would check the torsional, and you would also have a brown trace that would show you the torsional data. But the torsional data is shown on a separate screen. Then in the slow phase velocity graph, the red is the right and the purple is the vertical. Sorry, the red is the horizontal and the purple is the vertical. If you look here, the horizontal is about 20 degrees per second. The vertical is 0 degrees per second. Then at the bottom in the info screen, you will see the test type, the operator, calibration frame rate information, test time, how long the test was, 20 seconds, and then a begin time. What the begin time means is that if you decided that you wanted to begin analysis here where the cursor is, you would hit reanalysis and then reanalyze from cursor. And if I do that, then you'll see that my begin time is 7 seconds. So if I go back and say I want to reanalyze a full cursor, my begin time is 0 seconds. And then you have several points of information here. So for the slow phase velocity, for the horizontal right and the vertical right trace, a point is an individual point. So if I want to click on that individual point, that tells me it's 8.4 degrees per second at 6.5 seconds. And that's in my horizontal trace. The peak is the square here. So that peak is set. And then you've got 3 new values. So in the past, in VNG, typically we've always shown the peak for gaze. But really, a peak doesn't make much sense because typically when you have somebody look in the left or the right in a particular direction, that nystagmus is staying pretty consistent. So there really is no peak to it like there is to caloric. So what's really important is the average. And that's this new value here, the average. Now, if that nystagmus happened to be alternating, you may want to know what the nystagmus was at the beginning and what the nystagmus was when it changed. And so you need a min and a max. And that's what this is giving you here, the minimum nystagmus and the maximum nystagmus, or slow phase velocity. So these average min and max give you a lot more information about gaze evoked or gaze nystagmus or spontaneous nystagmus than what we had in the past, which was just peak. Now when you want to play back data, you just come over here and you click the play button. And what you see is the trace, the SPV graph, the eye movement, and the head movement. Now notice that I actually have the speed set on slow. So you can choose to do normal speed, slow, or slower. So those, if you slow it down, then you can really see the eye movement. The other thing I want to point out is that the pupil now shows a green crosshair. And so if you had something weird in your trace and you're thinking, what's going on there? You now know, was it just that the pupil thresholding was not good, or is that truly the eye movement for that patient? So let's stop this and let's play it back at normal speed. And you can see here, there's the nystagmus beating. And that's left beating, horizontal nystagmus. And the head is staying very still. Let's go back to our PowerPoint. So again, here's your info tab, which tells you your peak, your average, your min, and your max for your slow phase velocity, as well as individual points. Under the test tab, so that's under the info tab. Under the test tab, you have a list of all your tests. Now let's say that you had the person look left and you chose for them to look right. You can always click to rename a test. You can also delete a test or delete videos from a particular test. Reanalysis, we somewhat touched on this. You can analyze from cursor, you can analyze the full trace. Now if there was a beat there that you just thought was an outlier and you wanted to delete it, you would click to delete that point. Here's because you need to choose the right trace. Horizontal trace, vertical trace, torsional trace. And then if the peak wasn't set correctly, if you were interested in a peak, then you would choose where you want that peak to be and you would hit select the peak, or you can restore it back to the manufacturer's defaults. Regarding the gaze graph gives you a nice summary about right, left, center, up, and down. So you see all 5 traces there. Now the traces that you see there are the way you left them in your analysis tab. So if you collected more than 20 seconds, if you collected a very long trace, then wherever that cursor is, it's going to show you around that cursor. And then at the bottom here, so it shows you all the tests, and if you had more than one center and you wanted to, then you would choose which center you want included up in the top and included in this gaze graph analysis. Now the gaze graph analysis, the way this works is this triangle is the right, looking rightward. This triangle is looking leftward, so it's like you're staring at the patient. This top rectangle is up, middle rectangle is center, bottom rectangle is down. And then this is telling you which directions the gaze is beating. So you can see here for left, right, and center, they're all beating rightward. And then for up, it's beating downward, and for down, it's beating upward. And then the number of bars in that arrow and the number of tails in the arrow tell you the robustness of that nystagmus, the SPV value and the amplitude value. And then here shows you direction. Okay? And it's based on like 360 degrees. Once you've performed an ocular motor test such as gaze or spontaneous, when you're looking at your existing patient list, you will see the person sitting in a chair looking at a dot. That's ocular motor. You would then have a checkbox in that column to say, yes, this patient has some ocular motor testing. So regarding gaze interpretation, response within normal limits for gaze is absence of nystagmus. So for gaze and spontaneous, we look at a sign of peripheral or central depending on the type of nystagmus, the direction of the nystagmus, the presence of nystagmus with and without fixation, or with vision and with vision denied. Regarding gaze nystagmus, there's lots of different types of gaze nystagmus. So first you can have gaze-evoked nystagmus, and this is central. And this is induced by eccentric gaze beating in the direction of the gaze. So if you're looking left, it's left beating. If you're looking right, it's right beating. And usually this is absent with vision denied. Then you have square wave jerks, which is also central. And this is trains of small horizontal saccades that move the eyes away from the target and then return them to the target within 200 milliseconds during attempted fixation. Typically it's accompanied by a gait problem, but you also, if you see this, you need to ask the patient, have they been drinking a lot of caffeine? I mean, did they have their large coffee before coming in for testing? And sometimes in normal individuals, it can be seen in normal individuals, particularly in elderly patients. Then you have congenital nystagmus. This is horizontal nystagmus, which is intense and with increasing slow phase velocity. It usually increases with attempts to fixate. It's reduced by convergence, and it has a null point, and it's usually somewhere off center. Now, congenital nystagmus is often present at birth or develops in infancy. And so oftentimes, when they're reading a book, wherever they look, that's typically their null point. And then we have periodic alternating nystagmus, which is also central. And that's horizontal nystagmus that reverses directions about every 2 minutes. And it also has, along with conjugate eye movements. And then vertical nystagmus, which is also central. Downbeat or upbeat nystagmus. And this is present with eyes open at center gaze, sometimes brought on by or made worse by lateral or downward gaze, and can also be seen in the Dix-Hallpike maneuver. So one thing to know, if you get Dix-Hallpike and you see nystagmus, you need to really look at what type of nystagmus that is. And not just assume it's BPPV. So this vertical and central nystagmus can sometimes be seen in a Dix-Hallpike maneuver. Regarding spontaneous, a response within normal limits is absence of nystagmus or nystagmus less than 6 degrees per second. Spontaneous nystagmus is considered non-localizing, but typically we consider it peripheral. It's usually seen with vestibular neuritis. Primarily, it's horizontal nystagmus, unaltered by changes in head position and suppressed by visual fixation. So it would be suppressed by fixation, vision denied, and greater than 6 degrees per second with vision denied. I messed that up. Okay, Miko, let me start this whole slide over. Regarding spontaneous nystagmus, a response within normal limits is absence of nystagmus or less than 6 degrees per second. Spontaneous nystagmus is considered non-localizing. It's typically considered peripheral, and we often see this with vestibular neuritis. It's primarily horizontal nystagmus, unaltered by changes in head position and suppressed by visual fixation. So typically we do our test vision denied, and you get spontaneous nystagmus. Now, if you do it with vision, then you would see that there wasn't nystagmus. And then with vision denied, it has to be greater than 6 degrees per second. So regarding gaze-evoked versus spontaneous nystagmus, unilateral gaze-evoked nystagmus of any intensity is absent with vision denied at center gaze. Spontaneous nystagmus is greater than 6 degrees per second and is even stronger with vision denied at center